move on with our second rockstar speaker, Karmavir awardee last year, Dr. David Dror, the founder of the Micro Insurance Academy. May I call upon Dr. Dror to please come up on stage? Dr. Dror was awarded the Karmavir Puraskar for all his work for society last year. He's going to speak on a topic which is very dear to the heart about how can we recommend rural poor, what do we recommend to the rural poor to do when they're sick? Which is, I think, a big question for most of us to think about because most people die without any anything. Dr. David Dror.
Thank you very much, Jerry. Ladies and gentlemen. 6,000 years ago, people that lived to their 20s. 60 years ago, people lived to their 40s. Today, people live to their 80s and beyond. Medicine has taken a quantum leap. Virtually all the common diseases, and the rare ones as well, are understood, are curable, and we have the medicines to deal with them. People in this room would not have survived, some people in this room would not have survived 60 or 70 years ago. But we are here to live a comfortable, effective, useful, productive, long life. And as we speak, about half of humanity does not survive beyond 48 or 50. The only reason for that is not that we don't know how to deal with this issue. We know. The only reason for that is, to put it bluntly, money. The medical care has become one of the most important, largest industries worldwide. Bigger than IT, bigger than steel, bigger than banking, bigger than foreign exchange, bigger than anything you can imagine. When you combine the hospitals, the pharmaceuticals, the doctors, the nurses, the paramedics, and everything else, this industry is the largest single industry in every country, rich or poor. So, this industry functions along a business model which essentially tells you that you need to give the check before you'll give the checkup. You can't access care before you actually guarantee its payment. Most of us who can afford to will consume great amounts of it. We will in fact consume more than we need, and then we'll have the consumption to counteract all kinds of negative effects. We'll also consume our doubts, so we want a second and a third and a fourth opinion. We will also consume things that we don't really need. And I'm not only talking of cosmetic surgery, but all kinds of things that are on the margin of not really expressing need, but demand that meets supply, but does not meet the need. Now, in the face of all that, what do we do with the rest of humanity? With those who can't afford to pay that kind of money, who may be not even able to afford the transportation to a hospital that is too far, where there is no doctor, because we know, with all due respect, the doctors live where the wife can do shopping and their kids can go to school. That excludes most of the territorial space of rural India, rural China, rural Africa. But people live there. And if all were to move to cities, God forbid, it would be totally unmanageable. So, food security and the management of modern society requires that people should be able to live on the land where they have always been living, but not without normal modern amenities. So what do we do? That's the dilemma. The question is, what's the business model to actually make it work differently? I'd like to describe to you a few points on that. As we have been, my team and I, working on this in India, in Bangladesh, in Nepal, in Cambodia, in Vietnam, in a few countries in Africa, and there are some very interesting, useful lessons. We're facing a six-pronged challenge all at once. The first is that everybody has their own sense of priorities. If I were to tell you that I know better than you what your problems are or what your priorities are, because I'm better educated, because I'm more trained, because whatever, deep down, you wouldn't accept it. Nobody would. But this is how medicine is practiced. Now, if you want people to pay for it, then they'd say, wait a minute, I have my own priorities, and I want to put the money I have on my priorities. Now, my priorities in one village may be totally different than the priorities of somebody else. If I'm a fisherman, maybe my biggest risk and my highest priority is that if I have a severe accident on the boat, I should get from the boat, helicoptered, to where I can get care, or else nothing happens. If I cut sugarcane, I don't need that. My biggest worry is the snake bite. That doesn't happen on a boat. And every place has its own set of priorities. What does it mean? It means there is no such thing as one size fits all. Anybody who thinks that we can have one policy at union level and with that cover all of India, think again. Most people are not interested in those kinds of solutions, even when they're for free. But they never are for free. So when people have to pay, the first question is, wait a minute, those prices that you are telling me there, for consultation, for a medicine, for a test, for whatever it might be, are those prices of New Delhi or of Koraput in Orissa, of Hanumangar in Rajasthan? The prices are not the same. Don't give me averages. I'm not interested in averages. I'm interested in the price that I would have to pay in my location. In other words, the business model of averaging out on a national basis and creating averages with which one, in fact, creates lack of transparency, lack of pertinence, is the root model of how to be irrelevant, impertinent. The opposite of it is find a solution locally in each village, and sometimes for more than one group in a village. Now, I've heard many a times that this is very tiring, very difficult. To this I can only say, if you develop the right methodologies, it's doable. It is absolutely doable because we do it. So, to give it a coin, a phrase, a description, we need to move from mass production of health to mass customization. The mass would be that each location needs a customized solution because the problems are different and the costs are different and people are different. But the structure, the process, that can be systematized, and we have in fact. The third challenge is that most people, and certainly most poor people, are used to economic transactions in which, when they pay, they get something in return. If we want to pool money up front so that we can actually use collective action to deal with risks in a form of insurance, not necessarily commercial, but insurance nevertheless, mutual aid, there is no tangible return for the money. If there is no tangible return for the money, we are in a setup that is totally dependent on trust. And we know that there are social structures that survive in every culture based on trust. Marriage is one of them. The immediate or the extended family is one of them. They're not perfect. Not everything is rosy and cozy in that, but they work. Now, how can we do that to solve fundamental social problems. Other countries have done it. This has been the prevailing model before the modern state. Mutual aid societies were the prevailing model that created modern social security in Europe, in every country. So, if you can't move directly to the modern state by obliging everybody, or as it is called, mandating everybody to be insured, as it is done in all Western European countries, and as of next year also in the United States, but which you can't do in India, so what is the alternative? The approach has been, let's subsidize, let's give services for free. To that I say, no country in the world has ever been able to pay everything for everybody forever. Not possible. So subsidies by design are made not to reach everybody who is entitled, which means it creates a great deal of inefficiencies, great deal of inequities, and it's not me who is saying, many before me, much more prominent and much more knowledgeable, have said that only 10% of subsidies really reach their destinations. The rest is leakages on the road. So if we need to collect money from people, we need to be pertinent for what they do. As I say, we have done that. We've done that in Kalahandi in Orissa. We've done that in Vaishali in Bihar, in Rasulabad, in Nepal, in Vietnam, and in other places. So what are the basic take-home messages? The first, willingness to pay for pooling of risks is not a reflection of actuarial calculations. It's not even a reflection of the true price. Take away profit, take away administration. It is a reflection of trust. It will always be below par in the beginning. And as we see people trust the system, their willingness to pay will increase. We have seen it when we started with 100 rupees per person per year. We're today with communities that want to pay 300 and 400 rupees per person per year. And these are communities that are, in every objective way, way below the poverty line. The second is, community involvement is not only possible, it's essential. People are maybe illiterate, maybe innumerate, but people manage their lives. And if you take them out of the paradigm, you have to pay, you have to deliver solutions. In a world in which nobody can afford to pay and nobody can deliver solutions, you have to put the community back in charge and adopt the principle of subsidiarity. Every decision taken at the lowest level possible, and only those decisions that really cannot be taken would move to the next level. The opposite of top-down. The third, there are government services. Those government services, however, can also be can actually benefit from this kind of awareness at the community level. Why? Because very many people have no idea what they're entitled to, have no idea how they can use it, and there is complementarity, there is no conflict. And finally, I have heard many a times the dictum that the market will make the solutions. To this I say, in India, but also in many other developing countries, the market is totally uninterested unless we're talking about middle or high net worth. Low net worth people are not of interest for the market. Therefore, the market needs to be developed from the demand side, not from the supply side. Demand-driven, needs-based, collective action is the formula that we have been promoting with considerable success, and which, in a very nutshell, I present to you here today. And I think somebody has distributed some material to give you a little more information if you're interested. Thank you very much for inviting me.
Thank you, Dr. Dror. Dr. Dror, a CONCLiVE Nobel Laureate. Pleasure having you with us again today. So those were some brilliant solutions for seeing how we could provide healthcare to the people at the base of the pyramid, if I may call that. I'm happy to inform you that I've worked with a healthcare company to create a low-cost solution, which is actually a syringe, which could be affordable and be actually recommended to people in rural India. And that's actually going to kind of take this company from being a $250 million company to a $1 billion company in the next 6 years. So it can become a part of the business model, provided managers think, but mostly they're not thinking because they're only catering to the market which is there in urban India. So I'll tell you more about that project later. Any questions for Dr. Dror, please? Yes, sir. Please stand up and tell us your name and ask the question, please, because we are recording everything for the Rex Tube, which is going to be available online.
My name is Vijay Pratap Singh. My question relates to two things. One is the kind of communities we're talking about and kind of risk cover that we're talking about through community risk covers like health mutuals and others. They are one solution, but in a rapidly community or society which has a migration as a big issue where people migrate from place to place for employment, and how such if risk covers are effective if they are in the first place. And then I would like to take on your reflections on the Rashtriya Swasthya Bima Yojana as well.
The question of migration is only partly really relevant. A lot of people migrate for economic reasons. They migrate for a job, or they migrate during a season where they can't survive where they normally live. But what happens when they're sick? They usually go back to where their family takes care of them. So the issue is, where do people seek care? Not where they earn a living only. Now, of course, in a perfect world, you want to have a solution everywhere, transportable. You can check into any clinic, no matter what place you're in, and get super specialty services, if possible, free of charge. This is a pipe dream. It might happen, maybe, somewhere else. I come from a country which is a lot richer and a lot more experienced with both community and collective and national action. I can tell you we don't have it. I come from Switzerland. We're not ashamed of our healthcare, but we don't have that kind of healthcare where you can walk in everywhere you are and claim everything you want. It doesn't work. That's not the way it works. The way it works is that most people, and certainly most poor people, go back to their family, or somebody from their family goes to help them because there is no one else. Now, in terms of RSBY, Rashtriya Swasthya Bima Yojana, is a government-funded plan, executed through private and public insurance companies to deliver health care in hospitals through empaneled hospitals. Up to, the ticket is 30,000 rupees for a family of 5 per year. The issue is that there's 3 fundamental issues. If you would like to have a solution which is systemic, then you can't discern, you can't discriminate between what is known as APL, above poverty line, and BPL, below poverty line. Being above or below is not an immutable situation. You might be above the poverty line today, and because of a hospitalization for which you are not entitled, you would be below the poverty line. A lot of people are very narrowly around that poverty line. There are also people who are below the poverty line who are actually moving up. Not everybody is in the same situation. So the idea of looking at something static when life is dynamic is per se not a systemic solution. The other problem is that about 25% of the people who are undisputably entitled to, or should be entitled to, BPL status, and therefore BPL card, don't have it. They can't get RSBY, even though they are the poorest of the poor. About 25% of those who have a BPL card are not entitled to it, but the benefits are so huge that nobody wants to give it up. And there is very little true effective supervision as to the possession of that card. So again, there is a systemic issue, but when you talk about 25 out and 25% of the beneficiaries get it without a right, the numbers are much too big to look at it as a freak issue that will be resolved. It won't be resolved by itself. The third issue is RSBY does not create a single right. Nobody, no single Indian individual, citizen, resident, has a right to RSBY. It has never passed in Parliament. All they get is a debit card with which they can go to an empaneled hospital. They have no idea what they will get for it. They have no idea what the balance on that debit card is. This is not a systemic solution. A systemic solution is, first of all, you pass a law, and that law defines the rights of every citizen. If that law is unaffordable and Parliament won't pass it, it won't happen on the ground. If it is affordable, it should entail rights that you can actually claim and you can enforce the contract. The reason why RSBY operates through insurance company is because most people in India do not believe they can enforce a contract with an insurance company. The gaps are too big. The insurance companies are powerful and you won't go to court against them. It will take 15 years and it will cost more than the benefit is worth. So how are you going to enforce the contract? And therefore, insurance solution has to come from the bottom up. If I trust the process, I know who processes the claims, they know my reality, and I know it will happen, and there is an affordable ombudsman, that works. But if you take it away and you turn it into some kind of an obscure charity in which you don't even know what you're entitled to, that's not a systemic solution. The third point is RSBY does not cover outpatient costs. We know for fact that in India, 11% of total health bill is represented by hospitalizations, 60% by medicines, the rest by outpatient care. So, if about 90% or 85% of total health costs are not covered by RSBY, what's the deal? Most people still have most of their problems to deal with. So what we've talked about still deals with the majority of the problem.
Thank you, Dr. Dror. Any other questions, please? We have a question from General Sehgal.
Dr. Dror, I was with a doctor's convention last year, and I was shocked with the statistic that one of the speakers gave, that in India, from the lower middle class, a lot of people go below lower middle class, poverty level, if one single person has serious illness. Second, should we be thinking of hospices in India, as they had in Europe in the Middle Ages, for terminal cancer patients?
Let me take you for a moment to Cambodia, because we also work in Cambodia. It's a smaller country than India. It's a rural country. It's a country where, notably because of conflicts, but also because of history, most people live on the land and depend on their capacity to earn from the land. Now, in that Cambodia, 80% of the landless farmers, 80% of the landless farmers have become landless because of a single health event in the family. And selling the land to pay for that health care did not save necessarily the patient, but meant that it takes a full generation, 25 years, for that household to be able to replenish the land they had to sell. In the 25 years, they are virtually indentured labor. This phenomenon is not so dramatic in India. It's not 80%. But that phenomenon exists in India as well. We checked in India, in rural India, in Andhra Pradesh, in Orissa, and in Bihar, and now we are also doing that in UP and in other places. What actually is the mechanism through which people finance their access to healthcare? Not necessarily hospitalizations, access to any kind of healthcare. What we've seen is the amazing finding that about 28% of all households in the study needed to borrow money with interest. That is exclusive of all those who had enough current income or savings that they could deplete, or that they had sufficient help from the family and from friends, which was interest-free. We are only talking about borrowing money with interest from money lenders, the biggest source, from MFIs, from banks, and from similar organizations. 28% of households with any health event had to borrow. When we looked at the costs of this borrowing, additional to the healthcare, of course, the average cost of the financing of the care, not the care itself, was 5% of annual household income. Now this is amazing, because 5% of annual household income is the miracle number around which health insurance everywhere in the rich world is considered to be the adequate contribution. But that 5% in the rich world is for the care, not for financing additional to care. So, can we do health insurance amongst rural poor? They're already paying more than the care by a factor of 5% of annual household income. Enormous. We also looked at another group. It doesn't touch with terminal care, but it touches with non-communicable diseases. And there is a growing morbidity, there is a growing double burden of disease in India, both infectious diseases and very many more non-communicable diseases, diabetes, cancers, asthma, musculoskeletal problems, etc. What we've seen with the non-communicable diseases is that the cost of a non-communicable disease is essentially borne by intra-household subsidies. If a household does not subsidize the person who has the chronic disease, that person is condemned to death, because there is no solution for the payment of medicines which are life-threatening without which. So here's my answer to you. Not everybody needs to go to a hospice. They may reach their terminal lives in a family circumstance, in a 3-generational household, and many families still do that. But they need medicines. Those medicines are life-preserving, are life-improving, and are unaffordable unless the household pays for it. Now, if you have one chronically ill in the household can maybe do it. What happens if you have 2 or 3? You need a solution.
Thank you, Dr. Dror. We'll take one more question.
Dr. David, I'm Dr. Samuel Raj, working as a principal scientist with the pharma company. My question, you have given a very good presentation on the healthcare system. As you said, that it is true that in the village it's not reaching, and doctors are that, not to prescribe, and antibiotics also not reaching. But the question, my question is that one, we are fast moving towards the pre-antibiotic era. For example, if you talk about tuberculosis, initially it was given as multi-drug resistant tuberculosis. Then later it became extensive drug resistant tuberculosis. Now there is a recent report which talks about complete drug resistance, CDR, MDR, XDR and CDR. And this is not the only one case. Recently we have the dengue epidemic. And if you know that, there is no drug for dengue. And likewise, NDM1, New Delhi metallobutylectomy is one. And there is no effective drug for this one. The same way the drugs are becoming resistant, from multi-drug it is becoming complete drug resistance. We are fast moving towards the pre-antibiotic era. We need antibiotics, then only it can go to the rural. Even at the global level also it's not available. And the major pharma companies, they are not interested in discovering any antibiotics. So at this situation, what to do? How we can bring how we can avoid not going back to this pre-antibiotic era? Do we have any solution,
I don't know that we have a simple, straight answer to the question you raise. I'm also not sure that the situation is uniformly as you describe it. You may be right, you're certainly right, that drug compliance, certainly in rural India, is atrocious. Now, this relates not only to antibiotics, but also to other kinds of medicines. The basic rule of thumb, I refer again to a different study that we have seen, is that the vast majority of people, their first call of contact, their first health-seeking behavior is not to go to a doctor. They go to what is sometimes called quacks, rural medical providers, RMP, LMPs, etc. 70% of health-seeking behavior in rural India, the first point of contact is to that level of provision. Now, what do these providers do? First of all, they come home. You don't have to go to their center. Secondly, they give an injection, because people think that injection is the only way to get healed, or maybe a pill, for 1 day. And if you feel back tomorrow, if you feel okay tomorrow morning, no problem. In other words, we have here a model of doorstep, quick fix medicine that costs 25 to 50 rupees for the encounter, less than the price of the transportation from the village to the CHC or PHC. Now, if this is the prevailing model, and as I said, 70% of the first health-seeking situations refer to this, it means that if that provider will not come back the next day, you have atrocious drug compliance. We want quick-fixed medicine at the doorstep. We don't want medicine that heals. What you're talking about is medicine that actually has a certain logic, where you continue taking medicines beyond the moment where you feel that you're about to die or that you're in great pain. Antibiotics usually require a course of 5 to 7 days, and in some cases much longer than that. But people do not take it because it costs money, and it costs a lot of money. So the moment they feel well, they say, this is no longer prioritized need, the one I referred to before. Now, to bring drug compliance requires a totally different pricing of the access to medicine, a totally different access to providers who actually follow up and encourage drug compliance. But this does not exist. Does not exist. So if you wanted a systemic solution, you again need to create a mode of behavior which is communal. What does a responsible adult do? If a responsible adult is part of a community that has a responsibility to the health of that community, we're starting to build networks that are small, that are modest, that live within the funding that exists locally, but that can actually promote what you're talking about. If it is all supply-driven, and the whole idea is to sell as much as possible at the base of the pyramid, at profit margins ex-factory, which range between 500 and 1,000%, we don't have a solution. But that's the reality today.
Thank you, Dr. Dror. Some brilliant and deep insights on the healthcare sector, not only in India, but across Asia. So thank you so much for that.
Thank you.
So I'm very happy to note that we are running absolutely on schedule and we are like on time. So it's time for lunch. We break now, but please come back at 5 to 2. So 5 minutes to 2, please be back in your seats, because we have some firebrand speakers in the afternoon, like Alika, like Carmen. We also have a global philanthropist, Michael Norton. So please come back on time so that we can stay on time. Thank you so much.